welcome to episode 3 of Ben and Glen podcast. So, we covered previously on the hip impingement. So, one of the queries we got was, I think it's Richard from Manchester. So, I think he's attended one of our courses about the labral tear. So, labral tear seems to be quite a common occurrence and most patients are aware of it. So, Glen, from your understanding, what causes labral tear for somebody who doesn't have much understanding?
So it's an interesting one, that, isn't it? Because when you say the word tear, people always attribute that with trauma, and injury.
Accidents or something.
Actually, that's you can sustain a labral tear that way, but it's much less common. The vast majority of labral tears occur in the presence of bony abnormality. So either an FAI, which we spoke about on an earlier podcast, but just for those of you that might not have missed that, FAI or impingement of the hip is a change in the bones of one or two of the hip bones that make up the hip joint, so the ball and socket. So you can get an increased bony formation here on the neck of the femur, or an increased bony formation here on the acetabular rim, and then over a period of time that can cause trauma to the labrum. Also, you could have a dysplastic hip, so the coverage of the ball and socket might be reduced, and then people with this kind of hip morphology will rely more on the labrum for load and support, which is not what it's designed for. So it can get damaged that way as well. So that's the vast majority of clients that you see. It's almost part of a continuum. So they'll have impingement of some description, for example, do some kind of exercise or activity that will continually load. Normally it's the anterior as well, normally it's at the front, and then after a period of time you'll get damage and fraying and tearing of the labrum.
And we're seeing more and more people having scans and coming with a report saying they have a labral tear, isn't it? So it can be very, cause a lot of stress and anxiety in patients. So and we know that not everybody could be the source of pain. So a few studies show the incidence is anywhere from 50 to 60% of labral tear when you get aging. So do you think we have to always link with that patient systems, isn't it?
Yeah, this is the danger with scans in general, isn't it, where you look at everywhere really. You look at low back pain, you look at shoulder. If you scan people, you're going to find stuff. So it's trying to tie that into their clinical presentation. Is it relevant?
So that brings nicely to somebody with a hip or groin pain or the sort of thing. When would you think it's a labral tear rather than other conditions like an adductor or a hip flexors? What would make you think it's a labral tear most likely to be the cause of pain?
So as physios, we have a term called irritability, which basically assesses the levels of pain. So when people have a high irritability, they tend to present with higher levels of pain, and that is one of the big differentiators for me. When someone's moving from the realms of maybe symptomatic impingement into symptomatic labral tear, then the pain levels go up dramatically, and you tend to see things like pronounced limps after they've aggravated it, night pain. If you're getting them to rate it on a visual analog scale, it's in the higher numbers, and then obviously you're getting these clicks and
catching and locking,
which would be associated with pain. So if someone was limping through the door saying that they had played a sport 3 days ago, still recovering from it, getting pain at night, and they were presenting with a painful click and catch, then that's putting a fair amount of evidence into the labral tear argument, isn't it?
And the function wise, I would agree with you. A lot of these patients are not really at high level. They've stopped playing football or they stopped running for the last 3-4 months. So generally you don't find these patients are very at high level.
No.
So that possibly could give a clue as well.
Exactly. Yeah. They'll often give a story, won't they? Where I used to be able to, at football for example, I used to be able to play the whole match, and then I'd be sore for a day. Then I could only play half. Then I could only come off for 20 minutes. Then I couldn't play at all. So it tends to present down that kind of route, isn't it?
Yeah, and it's quite difficult to treat them because the pain levels are high. All you can give them the initial price, advice, take your painkillers and things like that. So it might need a bit of time to settle. And you also ask them about the flare-ups, how often they're getting it as well. Is it something you look into?
Oh, absolutely, yeah. So you want to take a good history. Also, you'll often find, especially with a female, I'm treating one at the moment who got married, so had a big motivation, if you like, to lose some weight and look good in the wedding dress. So took on a PT and started doing loads of box jumps and squats and things like that.
High level training.
Exactly. Yeah. And prior to that, she'd always trained, but had never pushed herself to that level. And then that was the predisposing factor for her. And quite often you'll see that they've started some new class, or they've started rowing at the gym or doing some new activity that would stress the joint more, and identifying that in your subjective is crucial, and also identifying if that's their goal, to get back to that, because that will affect your prognosis, isn't it? If someone's adamant, it's like again, I had a chap that was very passionate about CrossFit, and was really passionate about deep squats and overhead squats and stuff like that, and just would not compromise on that. That was his goal. That's what he wanted to do. Had a big cam, progressed to a labral tear, eventually would progress to joint damage. I would imagine, and the only way that he could logically pursue his goal was to go down the surgical route. There's no physio that would compensate for loaded deep squats repetitively, I would say.
And with the patient point of view, people come to me and say, I've got a tear, I don't think you can make much of a difference. Can you heal back this tear? Obviously, as therapists, we can't really, get the scar, the tear back again. So if somebody says to, the patient says, should I not have straight surgery rather than try physio, what would you say to them?
Well, the guidelines currently are 12-week conservative management, and I certainly have had lots of successful outcomes with clients that present with, what would appear to be symptomatic labral tears or FAIs, and conservative treatment has been all that they need. Education on what the pathology is and how they can modify their activities around it. Maybe tinkering with intensities and volume slightly, but I certainly am a big advocate of that initially anyway. I mean, there is the argument that even if they do end up going down the surgical route, they're going to be stronger and better educated for that anyway. I would also say though, I wouldn't just bang on with conservative treatment if they were making no progress at all. If you're getting kind of 6 weeks, 7 weeks, 8 weeks in,
still the same,
then I would expedite that. There's no point in spending 3 months with someone when they could be better served elsewhere.
You mentioned about clicking and catching, and a lot of my patients deal with few dancers who have the same problem. So obviously we don't want to say like every clicking and catching is a labral tear. So what do you think about the snapping hip sort of? Is it something you see as well?
Oh, absolutely, it's really common, isn't it? Particularly in the dance and yoga kind of worlds, So the difference here will be they've probably been able to snap their hips all their lives. It's a phenomenon we call snapping hip syndrome. So you often get the snapping either on the front of the joint here or on the side. So it will be a noise they're familiar with. It can be painful though, because there's little bursas that sit under the tendons that snap over the bone, and if they're continually doing a movement that's causing friction and rubbing against that, then it can become pain sensitive and the bursa can become irritable. There are tests to differentiate that out, but normally it's the history. If someone's
because that's a crucial point, because I was seeing a patient last week who was adamant she had a tear because she is having this new clicking. I think it was maybe she started a new spinning class where she's not used to those sort of movements, prolonged sitting. So sometimes it's just a training issue. So I think we have to reassure patients like every clicking and catching is not means like something is torn.
No, exactly.
So just some people have that flexibility, or they do like you do a lot of jiu-jitsu where your hips are doing a lot of extra motion. So you might have that sort of clicking.
It could develop. Probably need a bit more flexibility than I have.
So on that, so generally, from my experience, I say to my patient, it can take anywhere from 3 to 5 months, or sometimes more, because the patient wants see me twice, and then the job is done. Do you think it takes a bit as much as that, or what is your timeline?
It's a long recovery period, and I think the one key point that I would put across to them as well is sometimes they hear about the surgeries and that they're keyhole, and they liken them to knee arthroscopies and keyhole surgeries of the knee, and they're in no way comparable, and I'm sure you agree on that. So from my experience, the recovery time post arthroscopy, the quickest I've ever got someone running again is 6 months, and normally it's more like 8-9 months. It's more like a kind of ACL recovery time, I would say.
So it's not something you go for a quick fix.
No.
Only you've exhausted your options, and even conservative management can take, with physio, you're looking at months. Rather than, and sometimes, what are the patients whom we think are more likely to fail with because the thing people come to us, we think like we're going to fix everyone with a labral tear, and I would say more about 20 to 30% sometimes they just need to go for a surgeon. So obviously the one which have failed with you and me, what's your common points which they think more likely to fail with normal physiotherapy?
So I look at their goals. So if they're a professional athlete, for example, then I think they're going to require the surgery. I don't think they're conservative most of the time can get them back to where they need to be, particularly if they're doing a sport like hockey or something like that.
Rotational stuff.
It's rotational sport. Obviously looking at their bony morphology, if you've got access to their imaging, to their scanning, those that have particularly large cams, which is again the increased bony growth on the femoral neck, tend to require the surgery more than those that have a pincer, for example. And range of movement, so if they have a lack of range of movement, particularly internal rotation, and again they're doing a rotational sport, then you're going to struggle. If they're playing football and they've got 0 degrees internal rotation, you're going to struggle to get them back to that without.
And also the timing, sometimes we get patients who had this for about 4 years, 3 years, so they had more extensive damage. So it might not be possible, to reverse that. So there's an argument if you pick it up early and we can modify that. So ideally, I think our outcomes have been good with patients who have been less than 6 months, which is the best patient group, I think, because you can really make a big difference. If you see them for a long, because sometimes you get patients driving down. I think you're a patient driving down from somewhere like Derby or something, and there's not much you can do, isn't it?
No, I mean they've had the pain for best part of 9 years. I think. They've been running through it, and so it's difficult, isn't it, when that's the case, when something's so ingrained and so long-standing. Same with any area that we treat, isn't it? The quicker we get there, the better effect we can have.
And I think it's something which we really enjoy doing. So could you tell about our hip and groin service which we have on Harley Street?
So in our Harley Street clinic, we've got the hip to toe clinic, which looks at hip and groin, knee and lower limb, and foot and ankle. So we get specialist referrals from surgeons in all of those regions. It's me and myself and Ben, both specialists in lower limb. So that's what we really like to kind of get involved with where we can, and get a lot of people that have failed elsewhere. So a lot
for a second opinion.
A lot of physios refer to us for second opinions, and like I say, a lot of consultants too.
So hope you found that useful on labral tears, and as before, like any questions and queries, please email at harley-physio@gmail.com, and our links of our website is also down there. So hopefully we'll catch you on our next podcast. Bye guys.